Good morning to many and good afternoon to others. On behalf of the Black Press of America, the National Newspaper Publishers Association, we're very pleased to have this special international broadcast of distinguished physicians, distinguished clinicians, distinguished researchers to talk about COVID-19. And I'm very pleased on behalf of the NNPA to first introduce our moderator, Dr. Leon Webb, who will introduce the others, and we will get right into it. But on behalf of the Black Press, thank all of you who work so hard in healthcare, protecting the interests of African Americans and others in the United States and throughout the world to make sure that we not only understand COVID-19, but what it is we can do to protect ourselves and restore health to our communities. We appreciate all the first responders and all of you who are physicians who I don't think, in my view, get enough applause, get enough embrace, get enough support. So I want you to know that the Black Press not only appreciate what you do, but also we want to be an advocate for all of the great work that you continue to do during this global pandemic. Dr. Webb?
Thank you so much, Dr. Chavis. Let me start off by giving a thank you to you and the NNPA for even giving us this platform and allowing us to talk about these very important issues. Several months ago when the pandemic started, you recognized the need for public health professionals to get out there and talk about these issues, particularly to the Black community. And we were able to do that, and that was successful. So a couple of us are back today. We've added some new friends as well. So to all of our viewers out there, good morning if you're watching from the United States of America. Good afternoon if you're watching from the UK. We also hope that many people will join us later if you're not able to join us this morning. We have like a super exciting panel today. We have a lot of good things to talk about. There was an original 6 people on the panel that's been somewhat reduced this morning, secondary to technical difficulties and one unfortunate emergency. And so we'll make do, and hopefully we'll still have a great conversation this morning. I'm going to start off by allowing each panelist to introduce themselves. Before we do that, though, I'll give a brief introduction. I'm Dr. Leanne Webb. I'm an assistant professor of emergency medicine at the University of Virginia, where I practice with Dr. Hilton, and have been both working in the emergency department, taking care of patients, COVID-19 patients, as well as doing a lot of community outreach during this very trying time. So, Dr. Hilton, I will let you introduce yourself first. I'm going to let you introduce yourself again, but not on mute. Yes.
We did. And this is what we are in 2020. So I am Ebony Hilton. I'm an associate professor of anesthesia and critical care medicine at the University of Virginia, as well as the co-founder and medical director of Goodstock Consulting, which is a medical consulting firm looking at racial health disparities. So good to see you all again.
And Dr. Essien?
Good morning, everyone. My name is Utibe Essien, and I'm an assistant professor of medicine at the University of Pittsburgh School of Medicine. I study racial and ethnic disparities in cardiovascular disease. And like so many of us on the call, have really shifted that framework towards thinking about COVID-19, and really excited to chat with a few of my friends here on this call today.
Excellent. Dr. Hack, moving over to the UK side.
Morning, everyone in America. My name is Inam Hack. I'm a GP, otherwise known as a family physician. I'm a clinical senior lecturer at the University of Manchester Medical School. I co-lead on equality, diversity, inclusion there, and on widening participation to diversify the workforce. I also have an organisation called AskDoc, which in Greater Manchester is trying to educate, engage, and empower the local ethnic minority population.
Okay, and Miss Mita Mystery.
Hi, good morning, everybody, and good evening if you're in England. I'm Mita Mystery. I'm actually a journalist, a senior columnist for the Eastern Eye newspaper. So a lot of my columns and journalism work I do is looking at disparities in healthcare, and also I am actually a therapist as well. So I'm very interested in providing culturally sensitive care to patients in the UK. So that's my interest here with my friends in America and the UK.
Very nice. Thank you all for being able to join us today. We hope that our viewers and listeners will be able to enjoy this conversation this morning. I will give you a heads up, 2 heads ups. One is that Dr. Hina Shahid may join us as well. And if she does, if she's able to get on, we'll have her introduce herself sort of mid-show. And then also Miss Mystery may need to leave us a few minutes early because she is also practicing and has patient care to deal with as well this afternoon. So, but we'll essentially get right into it. We don't have a ton of time. We have a lot of issues to talk about. Dr. Ebony Hilton, I know that you've been heavily involved with the COVID-19 related racial and ethnic data, including a call to the CDC and HHS for comprehensive race data when there were only 300 deaths in the US. Now there are about 200,000 known deaths in the US from COVID-19. What does the race data show now? And have we made any progress in this area since we first started looking at it in February and March?
Yeah, you make up a great point in that we have been in this struggle for quite a while. And honestly, have we made progress? No. I feel like it's actually getting a little worse in that it's now starting to show that it's racial health disparities as it involves our children. So when we're looking globally, African Americans are 3 times more likely to be infected by COVID-19 in the United States. We're 6 times more likely to be hospitalized for COVID-19 in the United States and 2 times more likely to die. Now, what we've seen is this shift from it being targeting of in the media, this report of it being only old people or only people who were sick, right? So now we're seeing our younger generations become infected. And it really took a sharp shift right in the summer months where people start to be a little bit more lax on the social distancing and wearing a mask, and children started to be more mobile. And so we've called this the summer of change. And so what we've seen is a cumulative change since May. We had an increase of 720% of our children being infected. 19% of those are being seen in our Black kids. We've seen a 356% increase in the hospitalizations of our children. And with that, we've seen, unfortunately, a 200% increase in the number of deaths that we've had with our kids. And these are ranging from less than 1 year old upwards to, to the 18 to 20-ish range. And so with that, too, we're seeing a racial health disparity with 34% of those who have passed away have been African American. Now, the question is, again, why is this happening and when do we stop it, right? At this point, if Black people died at the same rate that white people died at, we would have 19,500 Black people still alive today. And we're still very much in the very stages of this pandemic because we don't have a treatment that is curable. We don't have a vaccine that is shown to be, as far as its efficacy. We are still learning new things every day. So it's something we need to take seriously.
Yeah, I agree with that. It seems like there are a lot of contributing factors to that. And we've been talking a lot about that over the past months. Dr. Essien, I know you are an expert essentially in health disparities even before the pandemic hit, and you sort of targeted your expertise specifically to health disparities related to COVID-19 in the United States. Can you talk to us more about why COVID-19 is ravaging Black and Brown communities here disproportionately?
Yeah, so I always learn so much when I'm on the call hearing from Dr. Hilton. So I appreciate her providing that lens and perspective. As we've been thinking about this issue over the last now 6 months, particularly here in the US, and I look forward to hearing from my UK colleagues, we've really been breaking it down into 2 buckets. So first, the risk factor bucket, which includes clinical risk factors as well as social risk factors. And then the access bucket, which includes access to actual treatment, healthcare, and even testing. And so in the risk factor bucket, unfortunately, we know that as the data started slowly trickling in from China and from Italy, that some of the chronic risk factors associated with COVID-19 infection and severe infection, including cardiovascular diseases, obesity, diabetes, and hypertension, were far more common in racial and ethnic minority groups here in the US. Those conditions that were making folks at higher risk for severe infection were more predominantly seen in our minority communities. But that's not the only story. And I think the social risk factor story is really where I hope a lot of our conversation during this hour lies. The potential for folks being overexposed, as some of our colleagues have referred to it, either through their type of work that they do, their role as essential workers, or through the housing instability and the food insecurity that has put folks in homeless shelters or having to go out to really make sure they're providing for themselves and their families every week, and hadn't have the ability to store up food for weeks at a time. So I think that bucket is really critical. And then lastly, just the access bucket. And Dr. Webb and Dr. Hilton, with your colleagues at UVA, you all really called this issue out quite early in emphasizing the importance of equity in testing for COVID-19. Unfortunately, here we are, again, 6 months into the pandemic, and only 6 out of 50 states here in the US are even reporting whether race and ethnicity were collected for those tested with COVID-19. So we still don't know the very key factor related to race and ethnicity that will help us at least continue along safely across the continuum of COVID-19. And I think that that's really another important aspect of this issue and why this pandemic is really devastating our racial and ethnic minority communities.
Yeah, you bring up some really good points there. I think one word that we haven't used yet is sort of systemic racism or so-called necropolitics, especially when it comes to this pandemic. Dr. Hilton, can you talk to us a little bit more about that? And I'm used to hearing about systemic racism and dealing with health disparities. Particularly, they are very obvious in the emergency department, sort of working on the ground. But this term of necropolitics was something that was new to me. It was a new vocabulary word. I don't know if it was new to everyone else. But can you talk to us a little bit more about what that is and what that means for patients or people who are trying to seek care?
Yes, for sure. So necropolitics, it was a phrase that was actually coined out of, I think it was Cameroon. But the idea is that there are policies that we know that are directly harmful to your health. For an example, we can use Flint, Michigan, and the water supply. There is no way that someone who knew that this water was heavily contaminated with these heavy metals, that it would not be dangerous to someone's health, right? And so with these policies and everything that we're thinking about as far as the redlining of 1930s and the structuring of whether or not there were healthy food eateries within certain communities, or if there was environmental racism in the form of industries being able to be planted that spews toxins within the air. We talk about air quality now with the fires out in the West, but we know air quality is important too with industries and the byproducts of whatever they're producing, right? And so with these things, this necropolitics, those are the factors that are feeding into whether or not from baseline, if someone can be healthy or not. And really the public, whenever we're thinking of, I'm not in medicine, I'm not a doctor, I'm not a nurse, I'm not a respiratory therapist, how can I help? You can help by pushing your policy makers to look at these policies that they're putting into place and say, how is this impacting whether or not someone lives or dies? And do I support that or not, and vote those people out?
Right. And I think you bring up a good point there, but one of the ties that binds us to our UK colleagues is actually systemic racism. And so I am going to let them talk about that as well. Let's bring them into the mix. It's the morning time here in the US, it's in the afternoon in the UK. And Dr. Shahid has joined us. So I'm going to let you introduce yourself, and then I'll pivot to ask Dr. Hack a question.
Sure. Thank you so much for having me and for hosting this really important podcast. I'm Dr. Hina Shahid. I'm a family physician in the UK, and I'm also the chair of the Muslim Doctors Association, which is a nonprofit that looks at health promotion and health policies that affect outcomes in the Muslim community in the UK.
Thank you so much for joining us. I know there were some technical difficulties this morning, but we're so happy to see you. Okay, so let's talk about what's happening in the UK. I'm going to pivot now to Dr. Inam Haque. Dr. Haque, you're a frontline provider caring for patients during this pandemic as well. Almost 42,000 deaths in the UK have been attributed to COVID-19 at this point. Can you tell us what you're seeing on the front lines in the UK, and if there's anything that Dr. Hilton and Dr. Essien have talked about so far that resonate with you as a provider across the pond?
Yeah, so across the pond, it is quite surprising of the similarities. And I think from our previous discussions we've had with Dr. Hilton and Essien, we thought that having access to free healthcare would be make a massive difference compared to the insurance system in America. But what we found is that the figures are still very high for ethnic minority communities. So I work in central Manchester, where about 41% of our population is non-white British. We have a massive Pakistani population and Bangladeshi population, and an Afro-Caribbean population that's quite significant as well. And what we find on the front line is a lot are being affected, unfortunately. And it does fit in line with what my colleagues have mentioned in America. There is systemic racism. There are barriers to healthcare. There are issues related to the environment and housing, the jobs, the type of jobs patients from ethnic minorities are doing that will expose them to COVID-19. And you know, at the end of the day, the risks are there for both the practitioner and the patients as well. The Bangladeshi population, which I'm from, is 2 times more likely to die of the condition. But this is not related to the ethnicity. It's not related to that essence. It's related to the disadvantages that the community has had. What we've also found is that a lot of the community may not have access to the correct information as well, and misunderstand what is coronavirus and how it impacts and how it affects as well. And it basically is a manifestation of what Ebony and Utibe were saying, that it's a manifestation of the inequality that was there already as a society to many ethnic minority populations, particularly those who are from lower socioeconomic backgrounds. And COVID has just exposed it. As a frontline clinician, you know, the worries are there for my patients, the worries are there. And unfortunately, our government hasn't helped either. I mean, not to get too political, but their management hasn't been very secure either. We're going through what we believe to be a second wave at the moment. So work has been a nightmare in primary care at the moment. Yesterday, I was just completely shattered because of the concerns, the worries that families are having. They're contacting their GPs. The tests are not conducted in primary care. They're outsourced to another provider who have not got enough testing kit available. So at the moment, my 2 children have got a cough and a fever. They're well, but they've got cough and a fever, so they're self-isolating at home. I'm self-isolating, but I'm working for the university today, so I don't need to go in. But we've been waiting since 8 o'clock to try and get an answer, and we're on a priority list as well. And I've just got an email now saying we'll just have to hope. We'll just have to hope you'll get a test, because without the test, we can't safely go back to clinical practice either. So it's an organizational issue, systemic racism, which has worsened the situation, and this has brought to light the whole health disparities, very, very common between the United States and the United Kingdom. And what's going to happen is the ethnic minority communities on both sides of the pond are going to suffer and are going to be markedly affected negatively.
Yeah, we know this is a very complex issue, but Dr. Hilton and myself and many other people, like, we think about Medicare for all, and we think about universal health care, and whatever Medicare for all means for you, it means different things to different people. But essentially, we talk about universal access to care. And it looks like from your end of things, even though everyone has access to care, it has not eliminated those health disparities, that you're still seeing those. Now, we know that access means many different things, not just can you go to the doctor, or can you get access to care, to care provider in our healthcare system. But it's still pretty shocking how they persist despite that, when in the US we sort of stand up this like everyone needs universal access is sort of a solution, a goal, something that we are hopeful for and optimistic for in our futures. So that's very interesting. The next question is going to be for Dr. Shahid. In the US, we continue to talk about these devastating effects of COVID-19, and we kind of categorize that more so along the lines of race, somewhat with ethnicity as well, but mostly we're talking about African American, Latinx, and indigenous populations, and less so the impact of religion on outcomes here. So that's not really a part of our everyday narrative. Can you tell us what you're seeing in the UK related to religion and ethnicity?
Yeah, sure. So even in the UK, actually, religion isn't something that's seen as an important determinant of health outcomes. And it's not something that's routinely collected. So, we're seeing problems with ethnicity. And if you add religion to that mix, the data really is very poor. But what we do know, and why it is important, is because, as you've already mentioned, COVID-19 has amplified long-standing inequalities and injustices. And what we know in the UK is that Muslims have the highest age standardized rate of reported ill health, disability, poverty, and deprivation. And so we campaigned earlier during the pandemic to get data on religion published. And there was a government report that was published at the beginning of June. And what that showed is that the Muslim population in the UK has the highest age standardized mortality rate compared to other religious groups. So, and we had predicted this because of what we know already, because of what we know about the structures and the systems that exist in society that systematically disadvantage Muslims, whether it's institutions and healthcare access, education. So this really just brought that to the fore. But what was really interesting in that report is when the statistics were controlled for ethnicity and for deprivation, that actually the independent effect of religion on health outcomes was diminished. So what that actually shows is that as Muslims, we embody multiple axes of oppression. So that's class-based oppression and race-based oppression, and that actually it's racism and structural violence and sexual discrimination that has contributed to the worst outcomes that we have seen in the UK Muslim population. And it goes back to this concept of biopolitics that Ebony spoke about right at the beginning, is how governments and policies make those decisions about who is going to live and who is going to die. And that is exactly what we've seen in the UK, where we've seen ethnic minority populations, religious minority populations being systematically disadvantaged, whether it's through access to healthcare, admissions, death rates, transmission, and also just wider, more widely, we've seen the impact on educational outcomes in children, on maternity outcomes. It's just an endless cycle that it's brought about. And really importantly, we've seen kind of media scapegoat minority communities like the Muslim population. So last week, for example, there was a significant government report that was published that shows that we're now entering a really critical stage in the UK with infection transmission increasing in the community. And what we saw plastered all across front pages of several newspapers and media outlets were pictures of women wearing the headscarf and mosques, as though we are to blame for this transmission, whereas in fact there is no data to suggest this. And the data actually suggests the contrary, that it is young white affluent people who are the main sources of transmission in the UK, but we saw our pictures being put and projected on media outlets. So, and that has led to a backlash of anti-hate crime. And we've seen, Islamophobia increase over the months. There was a report that was published earlier, I think in May or June, which showed that Islamophobia, so anti-Muslim hate crime, has increased in the UK. Also, anti-Semitism has increased in the UK because of COVID, where minority religious groups have been blamed for what is essentially, as Inam put it, systematic government failings to put in a plan to properly manage this pandemic.
Wow, thank you for that insight. Now, is Dr. Chavis still here?
Yes, I'm still with you. Yes.
Yeah, I'm going to put you on the spot. I know you just came in for a greeting, but I also know that you've worked for many, many years with the civil rights movement and advocating for minority communities. I wondered if you had a response to what you've heard so far, both from the US and the UK.
Absolutely. Thank you very much. And I think this is an issue that we not only need to discuss this morning and this afternoon, but I want to call upon all of you to continue this discussion after our first hour in terms of a rebroadcast or a reschedule, because I think what we are identifying is that systemic racism is not just a geographical issue in one part of the world. It is a global issue. The pandemic is global. Systemic racism is global. And if we are to come up with solutions to a global pandemic and solutions for a global systemic racism, we have to have global solutions. And I think that we have to work together. I'm so pleased to hear what has already been stated. And some of you know, in my early days, I actually coined the term environmental racism back in the early 1980s. My background, not only civil rights, I'm a chemist. And I saw that disproportionate impact of environmental hazards on the epidemiology and on the quality of life of our communities, the air that we breathe, the water that we drink, the food that we digest. For example, right now, 60% of all the children in Harlem have asthma, but they're not born with asthma. They get asthma because of the poor quality of environmental hazards that serve as a confluence, serves as a concentrated contradiction, almost the opposite of the quality of life. And housing segregation, residential segregation plays also a big role. And I was glad to hear Dr. Shahid say about the impact also on education, the children. So there's overall triage that's going on among ethnic and racial minorities all over the world. And we have to unite. And this is probably the first international broadcast like this. And I'm so pleased that the Black Press in America is sponsoring it. But I also want to say it's going so well. I was just writing some of my colleagues at the NMPA that we got to continue this. This is so great. So thank you, Dr. Webb and Dr. Hilton and Dr. Hawk and Dr. Shahid and Milton and Dr. Essen for your great work. The only thing I'm saying right now, we're scratching the surface. We got to dig deeper, and we look forward to continuing this discussion even as we reschedule. I think this could be a hot show in itself. I think it's so vital that we talk to one another, because dialogue and discussion helps us to refine what it is we can do, not only just to assess the statistics, the numbers, the data, which is very important. The science is very important. But after we get the data, after we get the science, what is it that we do together?
Right. And I love that, which is like, what are the action steps? Like, what can we do next? Because it does seem like, and it is a very complex, a very big problem. There are a lot of people who are working really hard on it. But I think myself, viewers, everyone wants to know, what can we do to combat these things in a meaningful way, which is a nice segue into our next guest, talking to our next guest, Miss Mita Mistry. So you are a cognitive therapist, but you're also a journalist. And so, you've been involved in these conversations about what's going on in the US and the UK from a therapist standpoint, but also you've been writing about it. And recently you published an open letter from several US and UK physicians, including almost everyone on this panel, discussing many of the systemic issues that we've raised today. What brought the group together, and what do you all hope to accomplish? And also, do you have a name?
Yeah, so I'm Mita Mistry, and this whole pandemic, as everybody has discussed already has highlighted the disparities, but nobody seemed to be labeling it as structural racism. Nobody's owning it. Nobody's calling it for what it is. And as Dr. Hina said as well, you know, in the media, it's almost like the blame is being pushed onto the ethnic minorities, whether they're living in multi-generational families or whether it's the vitamin D, or there's even conversations around the genetics being part of the problem. But we all know that that isn't the case, which is why with conversations through social media, we've started to expose the truth, and we want to debate and reflect and get to the bottom of this so we can move forward as a collective voice. You know, like we're all saying here, it's a global issue, but it's also a global conversation. So that's what we're hoping to achieve from this, is to have that global unity and move this forward and really get to the root of the problems.
It's interesting that you brought up the, you know, sort of genetic component of this. A prominent American medical journal called JAMA recently published an article which supported the idea of a biological or a genetic disadvantage of African Americans and other ethnic minorities, which may have caused them to be more vulnerable to COVID-19. And without getting into the weeds, specifically, the article talked about that, you know, racial and ethnic minorities essentially have like more of a receptor that makes them more vulnerable to contracting COVID-19. Yet we do see some successful control of the virus in Africa and the things that they've done there. What role does genetics play, if any? And that question's open to anyone.
I'm happy to start there. Thanks so much, Dr. Webb, for bringing that up and for everyone's remarks. I have to say that the legacy of structural racism, systemic racism at least in the US, and I suppose in the UK as well, is so long, and especially as it relates to medicine. For centuries now, folks have, especially scientists, have been trying to prove that there are biological differences between people who look like many of us who are on the call today and our white counterparts. The history and legacy goes back to the slaveholding days, when some of the Southern physicians of the day said that Black individuals had lower lung capacities, and that's why they had to continue to improve themselves by working in the fields. There were different mental health conditions that were named as reasons for why enslaved people ran away, or enslaved people weren't working as hard as they were supposed to. There's reasons scientists believe that Black skulls were smaller, and that's why intelligence was lower in that community, and that's why individuals weren't able to be properly educated or schooled, even though we forget the years of enslavement, the years of Jim Crow segregation that really made education impossible for people of color here in the US. And so science attempt to make race biologic and make there be genetic differences for a lot of the discussions that we have today is sadly so pervasive. And it didn't start with this new article that Dr. Webb just mentioned, including others all throughout these last few months. We've seen articles published in some of the leading medical journals that always slip in a little comment that maybe this is related to genetic variation. Possibly there are biologic reasons that we don't know or understand. And I think we must move away from that language and from that determination. Again, stop leaning on the centuries-old legacy of trying to believe that a lot of the racial differences and ethnic differences we're seeing are biologic. Dr. Shahid's comment that literally Muslim religion is associated with higher risk of COVID-19. How could one believe that that is a genetic function of this pandemic? And so I suppose my colleagues probably have a lot more to say there as well, but I think it's so critical to remember this history is long. In the
UK, we have a slightly different experience, but it's the British Empire, and it goes back to the issues relating to the empire. And what's happening in the UK at the moment is the rise of the far right and of nationalism, and I think that is worsening the disparities. The racism is more overt, as Hina mentioned well, and I think the country, unfortunately, doesn't seem to appreciate the issues that the empire brought. and the inequalities the empire brought, and the lasting damage that it's given to the fabric, not just of the United Kingdom, but to the rest of the world.
Yeah, I was going to make that same point of that. Oftentimes we, especially in American history, because we are so narrowed in our focus of learning American history, but we do attribute slavery only to the United States, and that's simply not true. Colonization and colonialism has been the true history of what is of Europe. So when we're thinking about these things, I think we have to go deeper to say, why is it necessary to maintain this system of systemic racism, and what great efforts are being placed into masking or giving these false titles of why this is happening? If you're putting that much effort into keeping a certain set of people underneath, there's a reason behind it. But regardless of what that reason is, what we know is that we as minority groups, we're mighty in number. We are very creative. We've always had to be innovative in our approach of how to survive, and not only survive, but also thrive during these hard times. And so I think it needs to be more things like this, where we do say, hey, we're seeing the same outcomes for our Black and our racial minority groups in the United States that you guys are seeing over in the United Kingdom. That's not a coincidence. How do we put feet to these words and start to make plans and start to not suggest, but to demand that these things happen? And it has to be on many different levels of approach, not only for the healthcare system and the implicit and explicit bias that we know exists within the hospital community. We know racism exists within our walls, and the practices and our outcomes, reflect that, but also within the community. How do we hold, just like we're having protests globally about police brutality, we need to have global protests about the defunding of our educational system, right? The fact that we spend in certain cities upwards of 50% of the budget going towards policing and 7% towards health and education. That makes zero sense. And so with this new shift, I do think we need to stop thinking of ourselves as isolated silos in the global front. And with that collective voice, there is huge power.
It's a big question. I'll let anyone else who would like to chime in have a moment. Okay, then I think that's a good segue. I really loved, Dr. Hilton, what you said about sort of this call to action moment for all of us. Many of our viewers may actually be struggling with where to start. And honestly, like all of us up here are healthcare providers, and Dr. Chavis is a civil rights activist. And so, for the viewers at home, I'm sure there are some people, I even struggle with this, there's some people struggling with like how to combat a problem that is so widespread and that is so complex and global and international. So I think it's great that here we're starting the conversation, but what does a call to action look like for this group? And what are some of the things that both healthcare providers or governments and viewers at home can do to help solve this problem?
Well, I call it 3 T's that you can donate. The 3 T's. So you can donate your time, your talent, or your tithe, meaning money to donation, right? So if literally, unfortunately, the problem of systemic racism is so big that literally if you throw your hat, it'll land on something. So whatever you're passionate about, if your passion is education, then go into that area and either donate one of those 3 things: your time, your talent, or your tithe. Donate to organizations that are trying to fight and uproot the systemic racism of education. Donate your time. Go and volunteer, especially now that we're having such an insult to the educational system, and we know that many of our minority children are not being made available to these technologies, right? And they don't have the Wi-Fi, they don't have the laptops, they don't have the resources necessary to keep up in class. And so they may need in your community, literally on your street, for someone to sit socially distanced, but to sit and read to them and teach them. And your talent. If you're great at sewing sew some masks. If you're great at making videos like these TikTokers, make a video that teaches people what to do and talks about systemic racism and play your part in that way. But it literally, it takes all forms. You don't have to be a medical provider. You don't have to be a politician. Everyone is needed in this fight because everyone, whether you benefit from it or you're impacted by it, is going to be influenced by systemic racism.
In terms of training, I mean, from my point of view, undergraduate medicine, I've just had a meeting with some students that were talking about discrimination that they've experienced and colleagues have experienced in the clinical environment, and it's that tackling this sort of either the microaggression, which they may not realize they're doing, perpetuating, or the pure aggression and racism that is in training, both at undergraduate and postgraduate level, and to try and introduce diversity-related training. We have a national organization called DEMA, Diversity in Medicine and Healthcare in the UK, and what we're trying to do is trying to educate those the educators basically for the next generation, providing role models, providing aspiration, but also getting rid of the things that draw people back. There's evidence that ethnic minority students do not feel a part of the main body of the student population at times, even though they represent a high proportion of the students in the UK, and that can then go into their postgraduate training and cause deficits for them. And I think until the system itself changes and also the people that are in charge and are running the system change, it's going to be hard. So I agree completely with what Ebony was saying about, you know, there is so much that can be done. There's so many aspects that we can be done, and whatever you throw it at, you're going to make a difference. So I love the 3 T's as well. I'm going to copy that if that's all right.
Right, I think the 3 T's are great. And I think that's something we all can do. I believe that we have to always define the problem as an act of self-determination. So often racial and ethnic people throughout the world, even though we're the majority of the world's population, we're treated like we are minute side action reality. And I think that we have to start pushing back on the history of Western philosophy, Western thought patterns that give rise, that undergirds keeping systemic racism in place. You have to understand there are economic benefits to those who are the practitioners of systemic racism. It's not because they don't just like us, it's because they profit off of keeping us down. They profit off of keeping us quarantined. They profit off of keeping us excluded. And so the demand for diversity and inclusion has to also be to more thoroughly and more resolutely define the problem of systemic racism as in its expansive definition, as well as a call to action to dismantle. We were able to dismantle apartheid in South Africa because we had to define what it was. And of course, it's interesting that the progenitors of apartheid in South Africa got it from the United States. You know, apartheid didn't start in South Africa. It started in America. It started in the UK. So I think that it's interesting that we find ourselves having to do multiple strategies almost simultaneously, not sequentially. And that's the nature of our struggle. And I think that we need an interdisciplinary approach where our best healthcare scientists, our best communicators in technology, because now we're using the internet and technology should be a lever to help create a more level playing field where people can at least get the information, who have been denied access to information that could help save lives, help protect lives, and help improve the overall quality of life of the communities in which we serve.
I love that point around the disciplines. I love that Mita is both a therapist and a journalist, and really, like Dr. Webb mentioned, helped us to amplify our message beyond just some exciting Slack messages and WhatsApp conversations, but to really put out how important this moment is. I think the journalists have been, over the last 6 months, doing a far better job than those of us who have had to be on the front lines and practice clinically, and but also maybe have been a little bit hesitant to kind of talk out against our institutions or speak out against our the systems or be political, like Dr. Hawk mentioned previously. And so I think that being interdisciplinary in this work, physicians working with sociologists, anthropologists, lawyers, educators, historians. Again, I think, Dr. Chavez, you mentioned this fact that South Africa learned from the US learned from the UK. This history of racism is not new, and I want to just continue to emphasize that. But it's also not individual. It's baked into the policies, it's baked into the practices, into the structures. And I think that is what this whole conversation has been about. But still till today, we see colleagues who are saying, I know what racism is. I live in insert southern city here, or insert, more conservative region here. And racism is not holding a Confederate flag, wearing a KKK hood, or calling someone the N-word. Racism is, like you said, Dr. Chavez, the practices that are kept in place, white supremacist practices that make it so that underserved minority students are continuing to learn in under-resourced schools and not being able to make it up this pipeline to avoid all of these structural issues around COVID that we've been talking about. And until if those of us who are practicing medicine can't even appreciate that, how can we expect our policymakers, our public health officials, those who aren't as versed in this empathic field to be able to do the same? And I hope that this conversation continues to push our colleagues to do that.
Mita, would you like to talk about sort of the role of journalism here? Because you all sort of connected through social media and you pinned this open letter. And I know that there was a list of suggested steps to take, but how was that received? And do you think that that's had an impact thus far?
I think it's been definitely made a lot of noise, and people in the right places know that there are physicians in US and it. I think people in these institutions realize that there isn't enough representation of the ethnic minorities, perhaps in the decision-making and the policy-making positions, which also is part of this systemic racism, that we haven't had those opportunities. So all these conversations, all these little actions that we're doing make a difference, because these people making those decisions will have to make way for people of color to have these positions of authority and decision make and be involved in the decision making process. But also in the media, I think it's really important that we have a balanced view, because like Ebony and Dr. Hina was saying, a lot of the headlines are plastered with images of people of color, when actually the reality is it's the white middle class young people who are spreading the virus. So it's important that there are journalists like myself, people of color, who provide that voice, that representation, and the balance. So we are being listened to, it is being taken seriously. There's a lot more conversation, but it's not enough yet. We've still got a long way to go. But it's a start. It's absolutely a start, a good start. But we have to keep going with it and pushing with it, because it's a long road, I think.
I agree with you. I agree. It's a very long road. There are a lot of doctors on this panel, myself included. So I'm going to throw this next question to Dr. Shahid. We talked a lot about the susceptibility or the impact of racial and ethnic minorities and this virus, this COVID-19 virus during this pandemic. How does that translate to the level of caution that we need to practice as we're trying to navigate COVID-19 in our everyday lives?
I think that's a really important question. I mean, like a lot of my colleagues have said already, this sometimes seems like it's such a big issue, and actually it is a big issue that, you know, we feel sometimes helpless kind of with all these structures and processes stacked up against us. And I really like the comments that I've heard from Dr. Hilton about, you know, breaking it down into the 3 T's. Dr. Chavez talking about you know, how we can have this multidisciplinary approach. But also I think it's important to look at good practices, and what Mita mentioned, you know, we are seeing a positive change. How do we keep that momentum up? We know as ethnic minority communities, we are at an increased risk if we were to have a second wave in the pandemic, which in the UK is a very real threat and reality. And so it's really important for us to reflect on the lessons that we've learned so far from the first wave, and see what positives have come out to protect us better moving forward. So, for example, you know, we've heard about the role of education, and, you know, it's really important to kind of, the way that I think about it is, you know, we need to change ideas, we need to change cultures, and we need to change policies, and we need to work together to do that. So, you know, we're already seeing, for example, and the US is better at this. So within medicine, we have a real issue with the way that, you know, medical schools teach kind of medicine. So, you know, it's very much centered on this biological approach. That's why we had that journal, you know, published things about genetics and biology. And that was the prevailing narrative at the beginning of the pandemic, when we were seeing ethnic minorities disproportionately being impacted. It made me feel really sad, actually, to see my own colleagues speaking about, oh, well, I think it's because of diabetes, or because it's vitamin D, whereas actually we know that the majority of health outcomes are socially determined. You know, there's so much data and evidence around this, but yet we still have our own colleagues that are talking about genes and biology, and that's, you know, and that needs to change, and it is changing, because we've now seen one of the first medical schools in Bristol who have made a commitment to decolonize their medical curriculum, and that's a real positive step, and, you know, something that the rest of the medical schools in the UK and abroad can learn from. Within our institutions, you know, there was a huge outcry. Over 90% of doctors who died on the front line were from an ethnic minority background. You know, that led to, again, the media was fantastic in bringing this issue to the fore, and a number of individuals, organizations all campaign for better protection of health workers. And we have seen, for example, mandatory risk assessments now being put in place. We are having conversations with heads of NHS hospitals who really want to take this issue of diversity seriously and inclusion, because it's not just about having people and numbers there, it's about having a voice, it's about having power to actually make change. And then, you know, advocacy and the role of, I think, as healthcare providers, we tend to have this kind of, I'm not sure, underconfidence or just cynicism about engaging in politics. Actually, this is our democratic right. We need to be political, and we need to use, you know, all our resources that we have, as Dr. Hilton said, the 3 T's, you know, whether it's our time, talent, or tide, we need to use that to really bring about change. And that's only going to happen when we engage in politics and when we campaign on policies changing, whether in the UK, for example, that's immigration, austerity, security, all of these that disproportionately impact ethnic minority communities. And, you know, we need to campaign on eliminating those policies that structurally exclude and marginalize ethnic minority communities.
Absolutely. I love that. I wrote down what you said. So influencing ideas and culture and policies. And it seems like from what I've heard on this panel and what I've been seeing over the last few months and even the last few years, this is work for everyone. We need allies, we need resources, and it needs to be interdisciplinary, and it needs to be, you know, global. This is a global conversation, right? So we have just a few minutes left. I want to, we have a question here about the UK, our UK colleagues' response to the revelation that President Trump knew about this deadly virus, or knew how deadly the virus could be, but did not reveal that to the public until this recent book, information about the book came out. I wonder if you all have a reaction to that.
Can I say Can I say something on that too? I was so jealous when Dr. Shahid said they're on the second wave, because America, we're still on our first wave. We've never allowed ourselves to come down because apparently we like to stay up on this number one. And last night, our president was stating that his plan for COVID-19's combating COVID-19 was herd mentality, as he called it. I think he was getting at herd immunity. But the thing is, Americans, what we need to know is that in order to achieve herd immunity, 60% of your population must be infected by COVID-19. And with our current mortality rates, that means that 3 million to 6 million Americans would die in order for us to achieve herd immunity. So that is not a plan. We have no plan. Which is why we need to band together to do the things that can keep ourselves from getting infected in the first place. But yes, I will be very curious to hear what you guys have to say about our leadership.
My reaction to Trump isn't he the guy that wanted to inject you all with detergent?
He did. I mean, and have sunshine like directed into our lungs, so that helps. So yeah, that's what we have. But you guys have Boris, so kind of like cousins.
Touche.
Right?
I think it's the USA and the UK have another similarity in the leadership of the government. It's the right-wing, almost populist movement. So all the decisions in the pandemic have been very much economy-led, which we're seeing in the number of deaths. So our reaction is that, you know, we feel for you, really, because we're in the same boat in many ways. So we feel for you. It's hard.
Right. Well, keep in mind, systemic racism is also economy-led.
Yeah.
You know, it is the economic, it is the planned economic benefit for a few at the expense of the many. And I think that needs to be called out. It needs to be challenged. And we need to find ways and means to put those kind of public policymakers out of office and get people in office that are not only culturally sensitive and culturally relevant, but who can help try to dismantle the reality of global
That's right.
apartheid.
So there you have it, folks. We've literally talked about our ideas. We've talked about the culture. And now we ended on a politics note as well, for those of you who were really waiting for that one. I want to say thank you to Black Press USA and to NNPA for allowing us to have this platform, to use it to talk to your viewers and your audience. Thank you for inviting me to moderate, and to Dr. Hilton for really being the force that sort of brought this group together. I'm going to let Dr. Chavis have the last words, because I think that you would have some good ones, good parting words for us. We have about 2 or 3 minutes left. So thank you so much.
Well, thank each one of you. Thank our colleagues in the UK. Thank our colleagues here in the United States of America. One of the benefits of this live stream is that we have brothers and sisters in Africa, in Brazil, in the Caribbean. I'm getting texts from all over the world where people of color are watching, are engaging, and we all need to work together. So, Dr. Webb, I would say that this is series 1. We will plan series 2, 3, 4, 5. We need an ongoing international global series of having these interdisciplinary discussions. But I like the fact that discussions are being led by our medical physicians, because at the top of all of our minds is the impact of the global pandemic. And I'm so pleased and want to thank all of you for your leadership. And as our brother stated, that sometimes in the medical profession, it's not necessarily a quietism, but people sometimes have to put their own careers at work in order to speak out. And I want to make sure that we embrace those doctors, those physicians who dare to speak power to truth. We want to make sure that we not only advocate for you, but we also support you. So you can rest assured, each of you, that the Black Press of America is going to be there to provide this platform, but also to, when we're not front and center, we also should be there to express our support. We have 230 African-American owned newspapers in the United States. We're trying to also connect with the minority press in the UK and Africa and the Caribbean, throughout the Pan-African world, so we can strengthen our voice. We're trusted, but I want our voice to be stronger. I do think that I want to end on a word of encouragement. The fact that we're having this discussion, I think, is positive. And I think people do need to hear not only what all the wrongs are, but to hear how we're going to right those wrongs, how we're going to correct those wrongs, how we're going to dismantle those wrongs. And I think that's what's the encouraging note. So I want to thank all of you, Dr. Webb, for moderating, Dr. Hilton, Dr. Hawk, Dr. Shaheed, Dr. Mita, and Dr. Essen. Am I pronouncing your name right, Essien?
Essien, that's perfect. We'll get that name on the map.
All right, thank you. But appreciate all of your leadership. And we look forward to our next round of interdisciplinary discussion.
Thank you. Have a good morning and a good afternoon for our colleagues in the UK. Bye.
God bless. Thank all of you.